by two eminent speakers from India, Dr. Sadhana Mangwana and Dr. Ankit Manther, to cover the topic of TTI testing. As we all know that testing for transfusion transmissible infections has been set as a prerequisite for blood safety, as it is declared by the 8 memoir that have been published by the WHO for ensuring safety of a blood supply in national blood programs. So in this webinar, we would be having two important aspects to cover. The first aspect, that is the fundamentals of TTI testing, that would be covered by Dr. Sadhana Mangwana. Dr. Sadhana Mangwana is a director of transfusion medicine and immune hematology at Sri Balaji Action Medical Institute. She has been a dedicated and hard-working professional with over 33 years of experience in the field of pathology and transfusion medicine. She would be covering the first topic in our webinar, that is the fundamentals in TTI testing, and she would cover important points and best practices in ELISA, chemiluminescence, and a bit of NAT. So the floor is yours, Dr. Sadhana.
Thank you, Dr. Hadil, and thanks for accepting me as one of the speakers.
May I please interject? Before we start with the webinars, we would request our president, Dr. Navjyoti Chaudhary, sir, to please say a few words.
Yeah, definitely.
Formalities. First, actually, I'd like to thank Dr. Hadil for her, hard work to organize this, webinar, and thanks to Ankit and Sadhana, because it's we know they are the best few speakers from AATM and with lots of experience, and I hope members from Iraq chapter will be benefited. And we have, as we have discussed already, we have a meeting with all our country chapters to decide what are the scientific activities they are going to hold for 2025. And I understand this is the first one, and rest of the things you can discuss with our scientific team, and you can go ahead. Thank you, best of luck, and thanks to the participants as well as speakers. Thank you very much. I will fail my duty if I actually if I do not thank especially Dr. Aikas. There are lots of not running around, calling around and organizing speaker sometimes become a challenge. That's why we want to be more organized this year. Getting Dr. Hadil was there in our meeting yesterday. I'll request Dr. Hadil that if you can give around 4 or 5 speakers from your side and their topic of interest, so that they can be included as some of the speaker with a good amount of time for preparation. And thank you again, Dr. Aikas, Dr. Hadil, Ankit, and Saran. Thank you very much.
Over to Dr. Sadhana, ma'am. Thank you, sir.
You are mute, Dr. Sadhana. You have to unmute.
Is it my screen visible, sir?
Yes.
Screen visible and you can hear you. Please go ahead.
Right. Thank you, sir. So good afternoon, everyone. Thanks, Dr. Hadil, and thanks, Dr. Ekaj, for arranging and giving me this opportunity to connect with the Iraq transfusion medicine specialist. The topic is the fundamentals of TTI testing. So, though you all know about you've been doing in Iraq the testings for your all blood donation, but I'll just give a bit of the overview. The accurate testing of blood donation plays a vital role in safe blood for transfusion to be carried on every unit of the blood donated. And the TTI screening for donated blood and quarantine of blood or blood component are the critical processes. Blood is either released for clinical use or discarded on the basis of the screening tests. So, coming to the characteristics of a transfusion transmissible agents, We all know the microbial agents of importance to blood transfusion services are those that are transmissible by blood transfusion and can cause morbidity and mortality in recipients. In order to be transmissible by blood, infectious agent or infection usually has the following characteristics: presence in the blood for long periods, sometimes in high titer, stability in blood stored at 4 degrees centigrade or lower, long incubation period before the appearance of clinical signs, asymptomatic phase or only mild symptoms in the blood donor, hence not identified during the blood donor selection process. So a large volume of blood or blood components given to the patients during transfusion therapy. So even a blood unit has a low viral load may cause infection in the recipient. The blood transfusion services have effective screening systems to detect, segregate, and remove reactive blood donations. Only non-reactive blood and blood components are released for clinical and manufacturing use. So each TTI has one or more window periods ranging from a few days to months, depending on the infectious agent, the screening marker used, and the screening technology employed. Nucleic acid, as part of the native infectious agent itself, is the first detectable target to appear, followed within a few days by antigen and subsequently by antibody as the immune response develops. So various assay systems are developed for blood screening, which detects antibodies that detect an immune response to the infectious agent, antigens that are produced by the infectious agent and indicate the presence of that agent, and the nucleic acid, either the RNA or DNA of the infectious agent. In non-endemic countries where the blood donor population includes traveler to or migrants from endemic areas, alternative strategies may be required based on the selective blood donor deferral and or screening test. Like some infections such as CMV present a risk to certain recipient groups, especially in pregnancy only. And in this situation, selective screening of the donation for these specific recipient is normally adopted. Infectious agents that are present only in blood cells, for example, like malaria parasite, can be transmitted by all blood component except cell-free plasma. Those viruses that are present in plasma, like hepatitis B virus, can be transmitted by cell-free plasma and plasma fractions as well as cellular component. HIV is found in both mononuclear cells as well as in free plasma. So various infectious microbes which can be transmitted by blood are viruses, which are named here. Few bacteria like syphilis, brucella, we all know. Some parasites like malaria, the most important thing apart from the others, and the prion disease. So for doing any TTI, TTIs fall into two main categories. The one, those that result in chronic infection in the donor, and the donor may have been asymptomatic or experience an acute illness but may feel well for years post infection and therefore present to donate. And most TTIs fall into this category, like hepatitis B virus, hepatitis C, HIV, cytomegalovirus. And the second category is that those result in a short period of viremia, which then resolves. Donor may remain asymptomatic or have symptoms of infection at the end of the period of viremia, or there is no chronic phase of infection like in West Nile virus, Zika virus, or hepatitis A virus. Coming to the window period, periods of time during which the donor may transmit infection but testing performed will be negative. Suppose here, if there is a antigen or the point of entry, and this A represents the window period where the time before antigen is detectable on testing, while the B represents that window period, which is the time before antibody response is detectable. A latent period of immunosilence shortly after infection, when lab tests for markers of the infection are the non-reactive, that is the window period, and the blood donation given during the window period be classified safe for use and be placed in available stock, yet may be infectious. This is the window period defined for different testing by WHO in 2017. According to the WHO 2017 document, antigen or ELISA test, which belongs to ELISA, as well as CLIA, that is chemiluminescence. HIV window period is 14 days. For HCV, it's a 9, and the longest being the hepatitis B virus as the 42 days. And the tests which have both combo means antigen and antibody detection Then it is 16 and 30 days respectively for HIV and HCV, and which detects only antibody by ELISA or CAMI. The window period is 21 to 60 days. And for combo rapid diagnostic test, it has only for HIV, which is available for the HIV for 20 days, and antibody which detects the rapid test for HIV and HCV are 28 and 80 days. For IDNet, the window periods are 6 days, 4 days, and 15 days, respectively. And in one of the latest document I could find, they have given the revised calculated window period from 6 days to 5.1 days for HIV. And for HCV, it's 2.7 days. And for HBV, they had detected as a 16.6 days, depending on their study. Coming to the types of assay, various types of assays have been developed for use in blood screening over the past 3 decades or more. And the assays most commonly used are designed to detect either antibodies, as mentioned earlier, antibodies, antigen, or the nucleic acid. And the main type of assay for blood screening are immunoassay, and the most frequently are the enzyme immunoassay and the ELISA test. It could be the microplate enzyme immunoassay, chemiluminescent, heme agglutination or particle agglutination assays, or the rapid single use assays, that is called as the short form, the rapid assay, or it could be the nucleic acid amplification technologies. And this is a sample card for any rapid or single use assay test. And this based on the form of immunochromatography, in which added sample flows down on an inert strip and reacts with previously immobilized reagents. And any positive reaction is visualized as a dot or a band appearing on the device strip. It includes a control dot or a band, and that is used to validate the result, whether that rapid test or rapid card is valid or not, giving the negative or the positive results. And in this, there is always added the particle conjugate on this conjugate pad. And they are read visually and give a simple qualitative result within minutes. Various single-use assays uh, have a various principle in hepatitis B or HepaCard, maybe a different brand name in your country. Detection of hepatitis B surface antigen by antigen capture or sandwich principle. In hepatitis C, fourth generation, increased sensitivity for core and NS3 antibody using a combination of modified HCV antigens, that is core or structural antigen, protease or helicase NS3, NS4, and replicase NS5. In HIV tridot, it is developed using GP41, C terminal of GP120 and GP36, representing the immunodominant region of HIV1 and HIV2 envelope gene structures, respectively. And in malaria antigen test kit, as I got to know from Dr. Hadil, though malaria is not mandatory in their country, but just for the mention, the malaria antigen test strip is pre-coated with monoclonal antibody specific to a lactate dehydrogenase or LDH of Plasmodium species. Coming to the particle agglutination assays, it detects the presence of specific antibody or antigen in a test sample through the agglutination of particles coated with complementary specific antigen or antibody respectively. For example, Treponema pallidum hemagglutination assay, that is TPHA for syphilis. And in this, patient serum containing IgM and or IgG specific antibodies for Treponema pallidum antigens are coated the RBCs. So the reaction is given as a positive, as a homogeneous thing, and negative as the single dot. Reactive sample shows a scattered mat of agglutination at the bottom of the well, and the non-reactive sample appear as a compact button. Coming to the ELISA test, which I'll be dealing a bit detail. uh, ELISA tests have four methods of format: direct ELISA, indirect ELISA, sandwich ELISA, or competitive or inhibition ELISA. Coming to the principles of these four, the direct ELISA antigens are immobilized to the surface of microvell of plate and detected with an antibody specific for the antigen and directly conjugate to HRP or other detection module, like shown in this one. And in indirect ELISA, antigens are immobilized to the surface of microvell of plate. It is a two-step process. Primary antibody specific to antigen binds to the target, and the labeled secondary antibody against the host species of primary antibody binds to primary antibody for the detection. In sandwich ELISA, it is the most commonly used format. Two antibodies are required for different epitopes of the antigen. One antibody is coated to the surface of microbial plate and used as a capture antibody to facilitate immobilization of antigen. And the second antibody is conjugated and facilitate detection of the antigen. The next one is competitive or inhibition ELISA. It measures concentration of antigen by detection of signal interference. Sample antigen competes with reference antigen for binding to specific amount of labeled antibody. Reference antigens are pre-coated on multi-well plate. Samples are pre-incubated with label antibody. They are added to wells. Depending on antigen in sample, free antibody will be available to bind reference antigen. So more antigen in sample, then the left reference antigen is detected and the weaker is the signal. As you people have been doing in your centers about the ELISA test, a bit of the preparation that one should take care of. There should be accurate pipetting, avoid contamination of pipettes, and one should homogenize the reagents and samples prior to use. Do not combine different lot numbers of critical reagents, and the container should be clean. As regard to the testing samples, patient preparation or the donor preparation in general is not important for microELISA, but precautions in cases of previous vaccination, mother to child transmission is important. Venipuncture procedure, identification, clean material, preventing hemolysis, and appropriate anticoagulant uses is important. Specimen handling, especially the heat inactivation, is another point to be taken care of. Possible interfering factors should be known, like the structurally related antigen, sodium azide, precipitate, or particular matter microbiological contamination. And then coming to the dilution of the samples, homogeneous sample diluent and the test sample should be there. Correct volume of sample and diluent should be used. Proper mixing of sample and diluents. Pre-dilution in the tube. It should be the correct volume. Clean tubes. Label the tube properly. Transfer samples very diligently, and the sample should be homogenized. And if required, the pre-dilution is done in the wells itself. Coming to the dilution of the reagents. Pipetting of samples followed by large volume of diluent will result in homogeneous dilution in well. Pipetting diluents followed by addition of sample, minimizing the risk for contamination or carryover, but it requires proper homogenization and skipping of well. Time between adding samples and diluent should be minimized. Purified water should be used for reagent dilution, and the wash buffer should not contain any crystal. It should be without crystals. Coming to the best practices for ELISA, make sure that all reagents are brought to room temperature before using. For standards that are not single use, it is best to allocate the remaining standard for smaller volume into smaller volume and freeze them. And this will allow you to avoid the repeated freeze thaw. If you're not going to run the entire plate, ensure that the remaining strips are sealed in the plate bag with the desiccant to prevent moisture from degrading into the plate. Keep pipette vertical during dispensing and dispensing of sample and pipetting. It should in between, and it should be uninterrupted, rapid to minimize differences between the first and the last sample. Check for air bubbles, and if present, remove by gentle tapping of the plate. When pipetting, dispense liquid with the pipette tips held at an angle and not touching the bottom of the well to avoid the contamination. While it is not necessary to change your pipette tips between each replicate, it is strongly recommended that tips need to be changed between the different samples or standards to prevent contamination. One should pay close attention to the incubation time. As a general guide, the incubation time should not vary by more than plus minus 5 minutes per hour of incubation time. Plate sealer should be removed carefully in order to avoid splashing. Stick to prescribed number of wash cycle as given in the literature. Use of lower number of wash cycle will result in a higher background absorbance. Allowing soak time will increase effectiveness of washing. Rest and the rest volume should be less than 5 microliter. It is highly recommended that a plate washer is used, as manual plate washing can lead to higher backgrounds. And when washing plates, either manually or with plate washer, be sure to give the wash buffer time to work by adding a 30-second soak time in between washes. Multi-channel, sorry, multi-channel pipettes speed the ability to plate your standard and sample and lead to more consistent results. Correct pipette techniques should be applied, and don't reuse V-shaped trough. Otherwise, keep specific trough for each individual reagents. After washing plate, add next reagent immediately to prevent well from complete drying. Now coming to the troubleshoots, one is the high background color, and it could be the reuse of the disposable, contaminated pipette, contaminated washer, insufficient washing, metaline in water or sulfuric acid, incubation is too long or too high temperature, and the stop solution is not concentrated enough, and wet plate during the reading. So one should really take care of the plate has been dried up before the reading. And colored substrates can give the high background color. Rest volume of the conjugate, could be either too high or faulty pipetting technique. The second troubleshoot is there is no color or the false negative results. The reason are disinfectants in the environment or equipment, like we use the sodium hypochlorite or anything in our ELISA room that really gives false negative results. Skipped, one may have skipped any step, or one have forgotten to add hydrogen peroxide solution to substrate buffer, or forgotten to add substrate buffer or TMB or OPD, whatever is used in the kit. It could be the low color. Another troubleshoot could be the low color. It could be due to the wrong storage temperature of the kit, low pH of water, expiry dated kits being used, incubation time is too short, or incubation temperature is too low, contamination with sulfuric acid, reagents not adequately mixed with samples, reagents are not at room temperature before use, faulty dilution or preparation of reagents, wash buffer, sample or conjugate diluent, or it could be due to the use of non-fresh TMB substrate. So one should be very careful that every time the TMB substrate is made freshly, or it could be the wrong washing techniques, or it could be the reading. There could be the wrong or dirty filter or badly positioned filter or the strips. Other could be the false positive results. It could be contamination of pipette, washer, glassware, trough, or splashing of any specimen to the adjoining wells. Specimen could be inadequately clotted, contamination due to dust and bacteria, repeatedly frozen or thawed. It could be due to the pipetting technique, inadequate washing, controls not warm up to the room temperature. And then another is bad reproducibility within the plate, inadequate mixing of sample, control or reagents, incorrect reconstitution of reagent, faulty pipetting technique as is said earlier, contaminated pipette, air bubbles in well, washer overflow and well contamination, or deviating results in one column or one row. Again, the next one is the bad reproducibility between the runs. It could be due to the incubation temperature, different per run, use of reconstituted reagents. More than one technician are having use or performing the test, and they have a different techniques to perform, which can give rise to the bad reproducibility or incorrect storage of the kits or reagents between the runs. Another is the bad results in the vertical column. So one need to see where is the bad results coming, whether the row, column, or different runs. Then it could be the multi-channel pipette, which is contaminated. Its tips are contaminated with conjugate or sample. Channel is clogged during reagent addition, or forgot to put one tip or on the pipette. The next could be the washer. The channel could be clogged, bent, or too short, or contamination is there in well to well. Or technician forgot to add one sample in one column. Now coming to the chemiluminescence immunoassay, that is CLIA. It's an immunoassay technique where the label is a luminescent molecule. It can be direct using luminophore markers or indirect using enzyme markers. Advantages: they are more reliable, precise, technically simple, having a shorter incubation time from 40 to 60 minutes. This is the principle given. Here the capture antibody is already there. Then the target antigen is added with the biotinylated detection antibody. Then streptavidin HRP complex is there, which give the luminal substrate. After adding the luminal substrate, the reading is taken. And this is the one of the automated equipment performing the CLIA. Next is the nucleic acid amplification test, or in short called as a NAT. It is a molecular technique for screening blood donation to reduce the risk of transfusion transmitted infection in the recipients. NAT directly identifies the pathogen via detection of the pathogens in nucleic acid. The NAT has reduced the window period of HBV to 10.34 depending on the various kits, whether it is the mini pool or the IDNAT or the individual testing. So coming to the testing algorithm, one can use, especially for the ELISAs or CLIAs, when someone has performed the TTI testing. So if it is reactive, here in India, we are by FDA, we are supposed to repeat the test. So after doing the retesting twice using the original pilot tube or sample and the second sample from the bag, the tests are performed in duplicates. Then we need to see whether it's a confirmed reactive, then it has to be discarded, and the donor is counseled by the authorized individual, and the donor record is flagged to prevent the further donation. And if it turns out to be the negative, then we need to see whether it's non-reactive, whether it's a batch-to-batch investigation need to be done, whether there was some mix-up or what was the reason. And if one is confident, then one can release the donation into stock if investigation is clearly resolved and donation confirmed a non-reactive. But if again it is repeat test is reactive, then discard the donation, donor is flagged. But when it was a non-reactive, whether the one need to see if sometime the patient donor has come reactive, and then we need to follow the relevant algorithm. So what is look back phenomena or the procedure? Look back investigations are done when a donation from a donor who had given blood before and which was then non-reactive for TTIs and therefore considered safe for transfusion into a patient. Now they test positive for any TTI. Recipient of previous transfusion from the donor may be contracted and tested for the specific TTI. So one need to really take the history properly from the donors. The next is the traceback procedure. This is when a recipient becomes positive for a TTI following a transfusion. Donors who contributed components to the transfusion may be contacted or tested if they have not already returned to donate blood. Coming to standardization of TTI, I suppose the whole topic will be taken by Dr. Ankit, so I would just skip this. Now coming to QA program in brief. What is QA program? Quality assurance is basically all planned and systematic activities implemented within a quality system and demonstrated as needed to provide adequate confidence that tests will fulfill the requirement of the quality. Quality is basically the degree of excellence, reliability, fitness for the purpose, freedom from defects or contamination, and conformance to requirements. So, quality control for TTI is basically validation of the TTI testing, standardization of assays, participation in proficiency testing. The controls could be internal or external controls, whether coming into the kit or the can be the spy sample. External control can be EQUAS or interlaboratory program participation. And this is proficiency test is basically in this blind panel is tested 1 to 2 times a year provided by the proficiency testing agency or any organization. Here the test performance of a validated assay. It ensures the reproducibility of the assay, confirms skill of the laboratory in performing assay. It enables comparison of performance with other laboratories using similar methods, and it gives the quality control studies. So improvements in the donor history questionnaires and testing methodologies to screen blood donors have proved to be successful, and the residual transmission of infectious agents still occurs. And current strategies do not protect the blood supply from any new emerging pathogens. So, efforts are being focused on developing an effective proactive approach that can be applied to all products to reduce transfusion transmitted infections while minimizing the technical and financial burdens of screening individual blood donor. That is mainly the pathogen inactivation. It has a myriad techniques, including pasteurization, just to mention few, solvent detergent treatments, low pH incubation, nanofiltration, or the chemical compounds to cross-link DNA or RNA. So to conclude, decades of investment in the blood transfusion safety has largely restored confidence in the blood supply. Risk of TTI is low given the collective strategies spanning refined donor selection and testing, and the innovative strategies such as pathogen reduction could prove transformative by addressing infectious risk proactively, but still there is a need and opportunity to do better. Thank you.
Thank you, Dr. Sadana, for the very valuable information you shared with us. I really liked the part of the best practices and the troubleshoots because it really touches an important part of the ELISA assay, which we widely use in our transfusion laboratories. If you please, before we move to Dr. Ankit, I have two questions. Well, you mentioned something about the rapid diagnostic tests and screening and testing for donated blood. I wonder whether it is in the setting of low workload blood center. Is it enough, the rapid testing as a screening test?
It all depends on what is the workload and what is the sensitivity and specificity of that rapid test you are choosing. So normally the providers or from the industry which is available, so we you need to carefully choose what is being antigen or antibody being detected, and what is the sensitivity and specificity. So, like fourth generation test, especially the HIV, where there is or in HCV, so they can detect up to a good sensitivity. So, basically, you need to see what is available in your country.
Oh, so
And
when we
because
have,
India is very
yes.
vast, so here
Mm.
FDA has basically allowed in a far-reaching blood center or in the rural center where the facilities for the ELISA are not available, or as you said, the workload is less, but still we have to give some cover for the blood safety. If not up to the level of the NAT, but yes, some blood safety should be there. So not a single blood should be given untested.
So may I ask if I only have if I say I am in a remote area and only what I have is the rapid diagnostic test, what other level of safety I can employ so that I would ensure no TTI would be transmitted by blood?
As I said, no TTI is not possible because
Yes,
there
definitely, definitely. We all
everything
know
has,
this.
because the
Yes,
window period is again one important thing, one important role to play. Suppose, or the history or the donor questionnaire. So if the donor has not given you the honest history, because the
yes,
safety begins from the donor screening itself.
definitely. Yes, yes, definitely.
So that is very, very important. The donor screening, and we need to really train our staff, be the technician or the doctors, junior doctors, that the screening is very important, and the taking donors into confidence that they give an honest history to us about their personal life.
So
So
you mean, yes, you mean the good donor question you're covering, together with the rapid diagnostic test with high sensitivity and specificity would be due in cases of remote areas.
reasonably good enough, I would say.
Yes. Okay. Yeah.
Yeah.
My next question, please. It is about the HCV testing. As part of our national screening program, we test only for the HCV antibody. Is it enough, in your opinion?
So normally they are because it depends on again the what is your incidence or prevalence in your country.
Okay.
So what is your upper limit and how much sensitivity coming in your general population and the donor population? What is the difference? Because normally
So, yeah.
because normally HCV are tested for antibodies only. It is only the HBV, hepatitis B virus, which is for the antigen.
Yeah, it is HBV and HIV for the antigen antibody. If we,
Antibody.
yes, if we don't have NAT, and the points that we would consider in employing any test, the incidence, the prevalence, and the sensitivity and specificity of the test itself. Yes. Okay. Thank you, Dr. Sadana, for your valuable
I
information.
I would
Yes.
request if Dr. Ankit or Dr. Navjot Chaudhary wants to add something.
Yeah.
Over to you, sir.
Sar or Ankit? Okay, I take the privilege to start first. Yeah, Dr. Hadil, I would like to add one point. WHO
Yes.
has got the standard that if you have the blood collection up to 15 units per day, you can go, that's a very arbitrary number, 15 units per day, you can go for rapid test. That doesn't mean that you will not do ELISA or chemilucence or any other sensitive technique. These are actually the standard for remote places or something like a war-like situation that you are
Yeah.
going, collecting, giving. But as far as possible, if it's 15 units per day collection, of course, in India, there are many blood banks collecting 15 units per day. That doesn't mean they
Yes.
can do it. Number two, it depends the regulation in your country. In India, by regulation, rapid is not allowed at this moment. We are supposed to go for minimum fourth generation ELISA. Fourth generation ELISA, it is needed, or maybe chemilucence, or maybe something higher. So that depends again the collection, as Dr. Sadhana says, sensitivity. So you should collect some sensitive kit. Number three is that what type of, sometimes of course it depends upon the prevalence, but let us not go and complicate the things.
Yeah.
Then more basic point is that doing something is better than not doing anything. You have to do something, I mean, in any situation, whether it is a very, very remote place or, it's a sensitive area. About hepatitis C, Dr. Sadhana has already cleared it. It is that antibody for, usually we go for antibody for these two tests, HIV and HCV, and the antigen for HBsAg. And of course, if you can go for a higher test like NAT, it's better. Over to you, Ankit, if you want to add.
Yeah. Yeah. Okay. Thank you, Sir Chowdhury. I just wanted to make a point here. As part of our national screening policy, it has it that we should use the fourth generation ELISA. We already have the fourth generation ELISA when we choose the test kits that we use in the transfusion laboratories. And the other point I didn't get what is meant when we have 15 points per day. We should go for a technique more than the rapid diagnostic test, you mean?
No. In extraordinary situation, in very remote location,
Yes.
if you collect blood up to 15 units per day, yeah, the collection of the blood, that is a number they have given, any arbitrary number,
Yeah.
then you can go and do rapid test, because that is that also this is not a recent recommendation, around 7-8 years back or 10 years back. But
Hmm.
it should not be in our mind that, okay, WHO has said 15 minutes, we should do the rapid only. As your country regulation says, it is, fourth generation ELISA. Please stick to fourth generation ELISA.
Yes.
Yeah,
Yeah. In our
in,
country, it is not allowed to employ the rapid diagnostic test as a screening test for donors. It's not allowed at all.
yeah.
Yeah.
In our country, in India, we are talking about, because all speakers are from India. We
Yes.
usually use rapid test in many centers in apheresis donor, because these are something like a directed donor. They come for a patient. Patient has got low
Yes,
platelet counts. You have to do it immediately because ELISA need a batch, and
yes,
many center doesn't have a chemilucence. In that situation, some people they do the rapid test, take that patient, blood donor to the machine, and do parallelly either ELISA or chemilucence. So
yes.
this is the system. But yeah, go ahead, please.
In our country, the policy is that for the apheresis donors, we do the chemiluminescence.
Yeah,
Yeah, we skip
better.
ELISA directly for chemiluminescence because, as I already mentioned, that the rapid test is not allowed at all.
Yeah,
Yeah.
Then I
better.
must
It's
congratulate you people that your government is
much
really
better.
stringent about the blood safety.
Much
Yes,
better.
yes.
It's much better.
Yeah.
Over to you, Ankit.
Okay, thank you. Thank you, Dr. Chowdhury. Thank you, Dr. Sadana. So we'll move to our next speaker in this webinar, Dr. Ankit Mathur. Dr. Ankit is an additional medical director in the Rotary TTK Blood Center in Bangalore Medical Services. And definitely he has very broad experience in the field of transfusion medicine and immune hematology. You are most welcome, Dr. Ankit.
Thank you so much, and it's my pleasure to be connecting with you all. Is my slide visible? Am I audible?
Yes.
Okay, thank you so much. I would like to do this in the slideshow. Yeah. Is slides moving?
Yeah, it's okay.
Fine. Okay. Okay. Thank you so much once again. And after this discussion which you had just now, it's really looked like your system of infectious testing is very stringent and quite of high level. So we really don't have to uh, do so much of talking. So just a repetition, maybe some of the things for you. So as Dr. Sadhna just now mentioned about the various testing platforms or testing method which we can have for infectious disease testing, I would like to focus something about the quality assurance in the TTA testing lab, what we have. So even if you do a rapid test, quality assurance still remain the same. Your people should be trained, your the consumables which you use or the rapid card which you use up to the certain standard should pass from the quality and so on. So the basic quality assurance for any lab, whatever the testing you have, it remains the same. But some specific aspect about the quality control in TTA testing, which I would like to focus on. Our strategy of reducing the risk of infectious disease transmission will remain the same wherever you are. We want to be strict on donor selection. If we want to stress on repeat donation, low risk donation profile, then the processing of blood, screening of testing, storage, the better transfusion practice, and if we can have tracing or surveillance for the post transfusion after the transfusion, any surveillance wherever required, which is called hemovigilance system. So this remains the same from donor selection till the transfusion. We would like to reduce the risk of infection as much as possible. As Dr. Sadhna just now mentioned, we have a couple of platforms which are used for infectious disease testing, ELISA, chemiluminescence, or rapid card, and so on. And many centers nowadays use the NET testing, which is nucleic acid testing, to reduce the window period everywhere. But these are the commonly available tests. Every test has its own limitation, own pros and cons whenever we use this platform. And we are trying to reduce the window period from whatever we have in ELISA if we use the NET testing. So our whatever we do, the major source of residual risk will be some sort of window period. Even if we have a NET testing, still there's some sort of window period always there. So we cannot just eliminate the risk of infection transmission anyways, but we are addressing the risk of residual risk in form of window period. If there's some viral variant which cannot be detected by the current assay, if some specific population, specific country has some variant which are not covered by the kits, could be one reason. Occult infection or any error in the laboratory testing which we have. This kind of the risks are there to, even if whatever the good level of testing or strategy you have. So the laboratory errors, if we focus, we would like to reduce the laboratory error as much as possible. To reduce the laboratory errors, we must have a complete quality assurance system in the lab. As she just now mentioned about the ELISA and chemiluminescence system, it could be open system or a closed system. Open means any kit you can use, any company's kit you can use, or closed with machine will allow only one particular company's kit to be used. Nowadays, CAMI is considered better than the regular ELISA, which you see the excellent precision, reliability, high speed, throughput, as well as random access. Just now you mentioned for any the one sample for apheresis can be used in CAMI and you give a good result. We really don't have to wait for the complete batch if we like we do in ELISA. So CAMI gives some benefits over ELISA in terms of precision, reliability, high throughput, as well as random access. So many centers are moving from regular ELISA to chemiluminescence test, but still the CAMI and the ELISA test remains the main portion of our the TTI testing laboratory. It also allows some performance performance benefit in terms of quality control of sample check, assay control values, and repeat reactivity, whatever reproducibility this test gives. So this test has some benefit even after the ELISA test. If we talk about quality assurance cycles, it starts from the sample collection, the pre-analytic, analytic, and post-analytic, like sample collection, identification of the donor sample specimen, and then the transportation of the sample from the donor side to the laboratory side, acceptance in the laboratory side, and the lab side, whatever testing we do, the quality control of testing, which goes under the analytical phase. And after testing, how do we report? How do we convert this information of testing to the in our information system, like our LIS, laboratory information system, or blood bank information system? How do we translate this information? And finally, the unit is ready. So the whole cycle from the donation till the unit is ready, and a pre-analytical, analytical, post-analytic, everywhere the quality assurance of the whole process is required. So how do we use this data? Do we use this data safely? How the information is transferred from one system to another system? Everything like from your ELISA or CAMI system, if you transfer this information to your LIS, information remains the same, whether you are manually reporting or you have a interlinkage of your system. Everything comes under post-analytical. Everything comes under the quality information, quality assurance cycle. Some important aspect of quality control which are essential, applicable for everywhere. We want to have a policies and procedure for all the testing, even for the rapid testing. What is our SOP? How many minutes we have to wait after adding all the reagents? Everything is important. And strict, not only having the procedures or SOPs, strict adherence. People should be trained on the procedures, whatever we have, the training, the competence evaluation is again an important part of quality assurance. And like I said, whatever testing we do, how do we document this testing? So these are the pre and post portion of our testing, which is important. Coming to the analytical phase, we use some software set of controls which we have. If you look for our ELISA, the testing, we have some positive controls, some negative control to work on. On the basis of negative and positive control, we got a cutoff, and then we release our report. Then we release the blood, which is negative and positive, and whatever. And there are some physical parameters which will influence our testing, like incubation time, temperature, and so on. And the kit, the quality assurance of the kit, which will. This is an overall essential part of any quality control cycle. So I will be talking about the samples which we use apart from an internal control or the kit control sample. which as I just now mentioned, that we have some set of positive control and negative control given by the kit. So we have a 2 negative, 2 positive, 3 positive, 3 negative, something in different kits we give. And we are supposed to use all the controls with every batch of ELISA, and this is mandatory to release the report. So this we cannot avoid any circumstances. Yes, these controls has to be used. This is internal control. But apart from the internal control, it is advised, recommended, or should be used some sort of external control, third party control, borderline reactive sample, or so on. Anything you can call it. So it's called, sometimes people call it third party control, or some people call it external control. So this it could be commercial, or it could be the in-house made, but it can be used for every batch. So what is this external control, and why should we use this external control or third party control, or some people call it spy sample, or so on? Our kit control, whichever be comes in the kit, are generally positive controls are very high, and negatives are really negative. And we use these controls to find out, to calculate the cutoff, and the acceptance range of this is generally very high. So this will detect some sort of systemic error, equipment malfunction, and so on. But it might detect some sort of near miss. So we want to have something which is lower the cutoff, not like the positive control with a very high OD value, with a low OD value also. So whatever it might be going something wrong in our process, in our equipment, or in our the kits anywhere. So this can be detected. So it's a this quality this QC sample will be is like our smoke detector. So it will detect some sort of near miss, maybe something going wrong in your process, maybe something going wrong in your equipment, maybe something going wrong in your kit. So this will give us some sort of alarm before something is actually happened. So this will give us an alarm before the accident happens. But the kit controls are generally a give, okay, yes, accident has happened. So positive control is not past, means there's something wrong. So something wrong in the person, something wrong in the machine, something wrong in the kit. But it will give you the low positive control might still give you some sort of alarm. So this the control which we are supposed to use in the lab. And another reason why we should use, it's a compliance to accreditation. Many accreditation authorities, they want, yes, you should use third party control, which every batch, a spice sample with the every batch, split sample with the every batch, or anything like this. And it always gives some sort of confidence to the staff, demonstrate our process. Yes, our process is strict enough to we adhere to our SOP always. So these are some of the reasons which the reason we are supposed to use this external control or third party control always. As like I mentioned earlier, we can prepare these samples in-house using a diluted positive specimen, and we can aliquot and the freeze these samples for some time, or these samples are available commercially also. You can use for the testing. How to prepare an in-house the low reactive or the third party sample or external control sample. If we have a reactive sample, the high positive sample, keep on diluting with the serial dilution of this sample, and every dilution will go for ELISA testing. After doing the ELISA testing, we will come to know with the E ratio, or we call it sample to cutoff ratio, S by CO ratio. This E ratio will be calculated for each sample, and you start putting this on the graph. Anything which is between your positive control and your the cutoff value, anything in between will be your correct dilution to use this sample as an external control or as a third party control. This is how we prepare our in-house third party in-house the low positive control. How should we use this external control or third party control or low positive control? Every batch we have to use this sample if it is in-house. So once your one dilution is done, you like divide, like aliquot this into 20 or 30 aliquots, the number of batches every month, whatever you want to use. And then every day you have to take out one aliquot, use this and finish it. It has to be in the frozen condition. You cannot just keep in the tube and using the same thing for entire month. If you're using a commercial one, then whatever the company advised to keep this specimen in which temperature, we have to follow the instruction given by the commercial sample. And of every batch, this has to be used as a one particular sample. We use the cutoff like E ratio, and this information we keep on putting on our LG chart or any graph. If you are using LG chart, it's easy for you to understand. If you are not using LG chart, so go to Levigenic chart, go to Google, and it will advise you some sort of free available website where you can log in, create your login and start putting your graphs and your information in this particular graphs. So this is how we should use. First is how to prepare or start with the external control sample, how to use them in the practical, like in the lab. Third, when your E ratio is done, then start with the graph and start putting in form of chart, LG charts. So if you use LG charts of your own, you say machines LG chart you can use, or you can use go to Google and start Levigenic chart. It will direct on its own, or you can do this manually also using a graph paper. So anything is possible. So whichever way you want to plotting your graphs, it's up to you. But once you have your 20 sample ready, like 20 times, if you're done, then you can calculate your mean and standard deviation, and then your calculation starts. So 20 times you have to run of, and for every time your E ratio, if your 20 values, calculate mean and standard deviation, then you're with using this formula, you really don't have to calculate like this. There are many free available software or Excel sheet will give you this calculation, and finally your graph will look like this. So you will have a mean, and your every day's the samples value keep on coming like this. Say uh, 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 9th of October, this is the value. 13th of October, whatever is the value. So this is value is keep on fluctuating like this. Will graph will be prepared. If you are using some automated machine like Ortho's Camel Wilson machine or Abbott's Camel Wilson machine, these machines, they have their own software, and you just have to plot these values in their system, and this system will keep on giving you LG chart on its own. So you really don't have to go to some another Excel sheet and do it. But if you want to do manually, that's also possible. So your LG charts look like this. What information we derive from these charts? So we will find out some sort of random error, or if there is any systemic error. So like I mentioned, the laboratory errors is the another way which we want to prevent. And what kind of errors we expect? Sometimes the random error means it's just one time it happens. It could be because of some poor mixing, some sort of poor centrifugation one day, transcription error, or poor technical skill, which one day maybe another lab technician is doing this test today who is not fully trained in this. So this is just a one random error which has happened, one particular incidence. It could be systemic error. Systemic errors are generally because of if you change your kit control, change your calibrator, reagents are degrading. They are not stable now. So the reagents are deteriorating. Your controls are deteriorating. Your reagents are deteriorating. So these are systemic errors which you can notice. So the two types of error we can focus. One is called random error. Another one is systemic error. In systemic variation, systemic error, two things which we see. One is called shift, another one is called trend. Shift means if your all the values are one side of the mean, this is called shift. If all your values are on one side, but gradually increasing or gradually decreasing. So if you see in this particular picture, you will understand all the values are on the one side. So many values are on the one side, but there is no increase or decrease. So this is called shift. If you see there is a particular increase or decrease like this up or down train, then this is called train. So you have two systemic variations you can observe here. One is called shift, another one is called train. After having your all the LG chart 3D, we apply some rules which are called Westgard rules. These Westgard rules, some sort of uh, uh, it will give us a guide. Okay, where my test is going, whether it's pass, not pass. Am I getting some alarm? Should I get some sort of alert at this point of time? So there are some Westgard rules applicable in many labs. The people who are not in the blood bank or they have worked in the different labs, this is a typical laboratory rule applicable everywhere in the lab. And if you know about the history of behind this the Westgard, so apparently the person James Westgard who designed this rule, so it is, I'm not sure about the history, but it said that he had a teenage daughter who used to go out for the partying or something. So he made some sort of rule. If you say after 12 a.m., it's not allowed. So after 11, okay, this is one time you are allowed. After 10 p.m., you are allowed only twice. So something like this. So there, we have some sort of rules given by given by the Westgard rule, which we use in our laboratory practice. So these rules are 1 2s, 1 3s, 2 2s. Like means if you have one result which is above 2 standard deviation, it's called 1s. If you have one result which is above 3 SD deviation, it's called 1 3s. So this could be either random or systemic. Some rules are only systemic. Like if you have 4 times, if your value is above 1 standard deviation consecutive times, so this is called systemic variation. So we have some rules which are called either systemic or random, some sort of violation and some sort of alerts. So these are the rules. It is possible that some of the rules are not applicable for our day-to-day practice in the blood bank. Some are applicable, some are not applicable. That's absolutely fine. So how strict you want to be in your day-to-day practice, it's up to you. So some are warning rules, some are violation rules. So Westgard rule, say for example, 1 2s rule. One sample has one reading is about 2 SD deviation. So this is my mean, and this is my once this external control sample has given above the 2 SD deviation, above 2 standard deviation. So this is called 1 2s rule. So in blood bank, we consider 1 2s is a warning rule. We do not discard the batch. We still go ahead with the batch. But this is called 1 2s. It's a do not reject the batch, but it's an alert. Maybe there's some possible cause. So you have to do the internal analysis why this has happened. So this is called 1 2s rule. Similarly, this is called 1 3s rule. So we have a once the external control, your spice sample or the third party sample has given above or below the third 3 standard deviation. In blood bank, we call it this rejection rule. If you observe this, your batch should not go ahead with the we should not go ahead with the reporting. It should be rejected and repeat the testing once it is passed. So this is 1 3s rule. A 1 2s rule means your two consecutive control samples at the same level are either below or above 2 SD deviation. Again, it is a warning rule. So like this. So two external control samples, twice it has given 2 SD, like above 2 standard deviation. So this is called 2 2s, right? Similarly, you can have 4 1s. Like 4 and 1s means it's a shift. 4 times you can have a 1 standard deviation. So this is called 4 1s. So there are 10x rules. So 10 times it is above the one side, but only 1 standard deviation. So all these are different Westgard rules which are used in laboratory practice. Some in the blood bank, some are considered, like I said, warning rule, some of rejection rules. So rejection rules, you have to reject the batch, and start another batch of the same sample. If it is a warning rule, means you can still go ahead, but there is, you have to do the, find out the reason of why it has gone beyond your control. So whenever your batch is out of control, means rejection rule means out of control. You have to stop the testing, identify the problem and correct the problem, and then repeat the whole batch. But if it is only a warning rule, still you have to do the root cause analysis and corrective and preventive action. Find out what is the problem of what is the reason of this problem, and then repeat the run in case of rejection. Analyze the rejection and warning rule. Any whatever we have need to analyze what is the problem, what is the cause of error. It is equipment, machine is giving the problem, man is giving the problem, is people are not following the rule, or some new technician started working, he is not fully trained, procedure is not followed, or procedure itself is faulty, environment, reagent, and so on. So we need to find out where is the problem, then only we will plug the hole. So this is called fishbone analysis of root cause analysis: man, machine, method, measurement, material, mother earth, mother nature, which is environment. All these are contribute to your analysis, and we will find out, okay, this is the reason of my problem, and then I do the corrective and preventive action. Then we go ahead with our testing. To summarize everything, like we discussed in the beginning, okay, whatever the testing method you have, whether ELISA, CAMI, or rapid, anything, quality assurance in infection disease testing is important. And to have this, it is required to have the external quality control sample, which is called third party sample, low positive control sample, or anything, but we should have this sample. After starting using this test, the sample, we have to start preparing the chart, LG chart, which is living chaining chart. I give example. You can do it manually, using literally a graph paper, pencil, and eraser, or you can do an Excel sheets. You can do some sort of using free software, or if you are using automated machine, it will have on its own. After preparing LG chart, we have to apply the Westgard rules for our analysis. And whenever we have any rejection warning, a rejection sign or a warning sign, we have to do the root cause analysis. We need to find out what is the problem, what is the cause of error in this case, and what corrective and preventive action we need to take for this. So overall, regular monitoring will help us in the continuous improvement. So with this, I end here, and over to you, doctor, and any question I will be happy to answer.
Thank you, Dr. Ankit, for the very interesting and valuable lecture that you introduced to us. That was quite useful, actually. I just have 2 points to mention. It's about the in-house positive control that we prepare by serial dilutions. In our center, formerly we used to use the negative serum or plasma for neutralization, but currently I'm not quite sure about the reference. We use normal saline to avoid any possibility of contamination or interaction. I don't know whether you have any idea about this point. You have any comment, Dr. Ankit? Yeah.
Yeah, in our lab we use commercial specimen, but I
Yeah.
know the other centers, other labs which use in-house, they use normal saline. And you are absolutely
Yes.
right. This negative control may have some other proteins or something else which might interfere here. So for the
Yeah.
dilution, people use the normal saline. You are absolutely right.
Yeah, okay, thank you. Other point, I know about the LJ chart and the Westgard rules, but I have one perplexing point for me actually. That is the LJ chart we plot using 20 samples that we have already allocated from a sample we have frozen. And we have the plotted chart at the end of the month, right? 20 samples over a 1 month period, say, right?
You mean whenever the day you use, the day you have to plot this. So today's value you have to keep on putting on the on the graph, After 1 month, after 20 sample, you will calculate the mean.
Yes. My question is that we have already released results and samples over that period, over the elapsed period of 20 days. So how can we get back to, if we are in the setting of, say, a screening lab? How can we get to the results that we have already released and the blood pints we have already released?
Okay, so 2 points here to mention. One is for practical purposes, we use, suppose in this month, we are keep on, if we are continuously using the same LG chart, for this month also, we will use the previous month's mean. Previous
Yes.
month's mean will be applicable, and
Yeah.
from we are calculating the today's SD on the basis of previous month's mean. Understood?
Yeah.
And if you have any 1 3s deviation, that batch will be rejected. Rest everything is warning.
Yeah.
So
Okay.
if you have released the result, you still have to do the RCA, means root cause analysis. Fine, you have released the result, blood has gone, but now still you have to do the root cause analysis. What might have gone wrong? Whether it was person, whether the machine has some problem, or the reagents which we used on that particular day had some problem. This information of root cause analysis will help us in the continuous improvement process. And that particular day we have released the result, we have not done anything wrong, our
Yeah.
controls were passed. So whatever we are using, this is for the improvement, this is for the further safety. Is that
Okay.
is that correct? What
Yeah. Yeah, Dr. Sadana? Yes, I think Dr.
Yeah,
Sadan wants to ask something.
No, 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 no. Now, I just want to add.
Yes.
So, as Dr. Ankit has mentioned, that whether if you want to plot or note down the readings manually or freely available app which is using LJ chart. So, if you enter those value for that particular software which is available free also, or you are using automated system in which it will already go and be saved. So by simply looking at the value of your control, whether it is passing, going beyond 2s plus or minus or 3s, accordingly before performing your test, you can have a look at the control values as well.
Okay. Yeah.
That was
Okay.
my only point.
Yeah.
I hope it is clear for your this thing.
Yeah.
Yes.
Thank you, Dr. Sadana. That was quite useful. Yeah.
Yeah.
If we have any questions, let me see from the audience. Anyone is having any question? Yes, I believe no one is having any question or any point to add.
Yeah,
So,
Dr. Ahmed,
sorry.
please.
Sorry, I have one question only.
yes.
Thanks for this information. I, Dr. Ahmed from Main Blood Bank at the Qar province, southern of Iraq.
Yes,
I have
you're
only one.
welcome, Dr. Ahmed. Yeah, go on.
Sorry, when we examination the donation daily appear from 5 to 10 positive for hepatitis B core by ELISA. When we repeat this examination by chemiolysis immunoassay, which appear non-reactive, this problem.
So you mean the test was reactive for hepatitis B core?
By ELISA appear daily from 5 to 10 positive. But when we repeat by chemiolysis immunoassay about, which appear non-reactive.
Can I?
Yes. Yeah.
So,
Dr. Sad.
Dr. Ahmed, when you are having such a high positivity in your ELISA testing platform, but
Yes.
the very same sample are negative in your chemiluminescence, then you need to do a thorough root cause analysis along with your service provider, along with that company, that you have tested parallelly on both the platforms are tested, and why one ELISA system is giving such a high positivity, then the company needs to thoroughly investigate the reason. Either there could be a lot problem of that particular batch problem, so you have to involve the service provider also, giving the discordant results into two platform. Anything you
Thanks.
want to add, Dr. Ankit?
I
Thanks.
just want to add here, I'm not sure this particular instance. Sometime in ELISA, we see the carryover problem also, like one positive, if washing is not perfect, then it's keep on going positive in consecutive wells as well. Either the horizontal or vertical, both the ways. It happens in sometime in ELISA. I'm not sure, could be reason sometime if you see consecutive samples positive.
So this is what I mentioned for the troubleshoots. So I can share the slide also with Dr. Hadil, and for the
Yes.
circulation and for understanding. So you have to really look back why the problem is happening and so high positivity, whether it was your technical problem, technician problem, equipment problem, reagent problem, reagent storage problem. You need to really analyze everything.
Sorry, this problem only only with the habitat score, whereas other examination normal.
Then you need to talk to your service provider.
Thanks.
Excuse me, Dr. Sadana. I believe, Doctor, this is to you, Dr. Ahmed, as well. The principle of ELISA for hepatitis B core is competitive in ELISA, which carries high
Yes.
risk, I believe, high risk of false positive. So, as
Yeah.
part of our national policy, when we do the test with ELISA, we repeat doing any HB core that is positive on ELISA, we repeat doing it by chemiluminescence. When it is negative, it is considered as negative.
So once your government has already laid down certain guidelines, so I believe then you need to follow those guidelines. So they must have drafted the guideline depending on the incidence prevalence of your population, about your
Yes.
donations,
Yeah, this is
and
our national
about
policy. Yeah.
their all documents taken into consideration. So that is why they must have drafted certain guidelines for your country. So I believe that then you have certain guidelines from your government only, from your health ministry. Then you need to follow. If ELISA is positive and chemiluminescence is negative, then consider it as negative only.
Yes, this is what we do as part of our national policy for screening blood donations. Dr. Ahmed, have you listened to my comment?
Yes, thank you very much. Thanks.
Thank you. Yes, thank you.
Dr. Sadna is right. Follow national policy. You are safe.
Yeah, thank you. Yes, thank you so much, Dr. Chowdhury, Dr. Ankit, Dr. Sadani. Thank you so much for this interesting webinar.
Forgot Dr. Ikas.
Dr. Akaj as well, definitely, yes.
Dr. Ikas, you are here? Oh, you cannot miss him. He's a heavyweight. Dr. Ikas, this is a lighter way. And I think these are recorded already. And we are going to make it available in the YouTube if somebody is missing.
Yes, thank
So this
you.
is for the information of everybody. The webinar will be uploaded free of cost on our official YouTube channel. Please go to YouTube, search for AATM webinars, and
Okay.
you can have not only this webinar, but all the webinars that we've had in the last few years. It is completely free for everybody because at AATM, we believe knowledge should be free.
Thank you. Yes, thank you.
And knowledge should be shared with all.
So, though we are a poor organization.
we are rich in
like
knowledge,
us.
poor by the money part.
Money.
Poor in
Okay.
finance.
Okay, thank you very much,
Thank
everybody.
you.
And thank to all participants. We should have a group photo, Dr. Hadil.
Yes.
Sorry?
We
A
should have
group
a
photo.
group
Let
photo.
everybody switch on the
If
videos.
everybody can open their camera, if it is no.
Yes, a group photo, definitely, yes. Yeah.
Everybody is there? All participants. Everybody want to have a photograph? And it will go in, Dr. Hadil, you have got your own chapter in the website. You can
Yes.
manage by yourself. You can upload this photo in your website.
Okay, I would. Thank you. Yeah.
So nobody from participants?
Yes, I think they're not willing,
Okay,
unfortunately.
so what we'll do, we'll have the photograph for ourselves only. And I'll just take it now. Hello, everybody. Ready? 1, 2, and 3. Okay, I'll just post it in
Thank
the
you.
website. Thank you.
Yeah, thank you. Thank you so much. Bye.
Okay.